Thank you very much for allowing me to present this on behalf of Rui. His PhD is on the mathematical analysis of the shape of urine flow. And for men, as you're aware, the key aspect of urodynamics is to differentiate between the underactive bladder and the obstructed bladder. And the particular focus of this abstract is to look at the frequency content of free urine flow. The hypothesis being that we know that underactive patients complain more of straining in order to void. And that's using skeletal muscle that has a very much quicker action than the bladder muscle, which tends to be used more solely for the obstructed patients. The other aspect is that we know that detrusor underactivity is characterized by a failure to sustain a contraction for a while. And in skeletal muscle, the EMG signal decays, or rather the median frequency decreases with fatigue of muscle. So we might expect that a frequency component of the underactive bladder would decrease through the flow. So that's why we're looking on free flows to examine the frequency content. And by looking at the frequency domain, we're hoping to derive some non-invasive parameters to differentiate between the groups. We also have other parameters that you'll see in the other presentations that I'll briefly mention about combining. Now here are the outputs from the frequency method, where he looks at filtering the signal, so we get rid of the noise signals as well as the lower frequencies as well. And putting them through this filter, you generate what's called a fast Fourier transform, and it gives you a graph of the frequency content for each particular component. And if you look at the median frequency, we're hoping that we might be able to detect some difference between the underactive and the obstructed patients. This is the sum of the amplitude changes, which is the second analysis in this abstract. You can see that the top trace is the raw flow trace of the urine flow, free flow, and the bottom one has highlighted the rising parts and the falling parts. We're hypothesizing that an underactive patient, as they strain, would generate more rising components because they're able to affect it more without the obstruction. And again, those are filtered through a stop band and adding up together. So the results here are that if you look at the numbers, we have 104 obstructed patients, 93 underactive, and some free ones that were blind during the analysis procedure. I did not disclose the urodynamic diagnosis of these patients while Rui was doing the analysis. And you can see that the median power frequency has very good specificity. In other words, you can tell the difference between the groups to some extent, to a large extent, by looking at the power. The amplitude is different between the groups, but not very specific. If you look at the median frequency, we found that in DU it is lower than in the obstructed patients, which in fact is the opposite to what we expected. I was hoping that, or expecting that, a DU patient, as they strain more with skeletal muscle, would have a higher frequency, but in fact it turns out to be lower. However, the amplitude is what we expected, that an underactive patient can create more changes in their flow rate due to, we presume, their straining. So looking at the overall analysis, it seems that each of these indicators is not sufficient on their own to give good sensitivity and specificity. And in our abstract tomorrow, we'll look at the last two lines, which actually improve this by looking at a combination of all the factors to do with the shape of urine flow. But as that's not part of this abstract, I'll leave that for later. Thank you very much for your attention.
So it's potentially a very important issue. So, Jerry, I'm sure we'll test your flow rate.
Davis from New York again. I appreciate this. This is the second time I heard it, I think. So I'm getting it. If you give it a third time, I might be able to really understand it.
They're different aspects. Yeah.
The question, I mean, so is this dependent upon the patient straining? If a patient doesn't strain, what happens to this analysis?
We don't know, because what we're doing is analysing patients according to their diagnostic group, not whether they strained or not. And so we are hypothesizing that the DU patient would strain more because we know that they do complain of it more, but we don't know which ones. So the next stage would be to
I guess what I'm
divide them
asking
up.
is, if you take out the straining component,
Yes.
would this have any, because if you take out the skeletal muscle component, would you be able to look at, are there other frequency parameters that might make the distinction, or is it dependent upon having a fast muscle, if you will?
The changes in the urine flow rate will be more due to the straining than anything else.
Yeah, that's right.
The higher frequencies, I think people have analysed and found that you can't differentiate, because they were expecting turbulent flow to have higher frequencies from the obstruction. And I don't believe on the flow rate that's been seen. They do it from ultrasound, but not on the flow rate.
Thank you.
Yeah.
I can see a large sinister shadow. Is it Craig?
It's me. That was excellent, and I think I understood a small part of it.
Great.
But I think you've made it clear, if a person with a weak bladder strains, you can increase the flow, and we've learned an obstructed person does not increase the flow very much with straining. But an obstructed person who interrupts his flow with a stop test, even if it's just a sphincter contraction, will increase his flow. So how do you marry those two? How do you know if it was a strain or was it a accidental or even voluntary stop test that's responsible for the flow?
Yeah, you can't be sure. The only thing in support of our hypothesis is that these were all supervised flows during urodynamic tests where patients were asked not to pinch the urethra or to do a stop test. So none of these were free flows in a closed room. I think these were all the urodynamic test flows. So there was an element of supervision in this, yeah.
Well, thank you, Andrew. Present it another 4 times and we'll get it. Perfect. Thanks.